welcome everybody. Hope that you're all well over in Lusaka. Um, we are going to run the next talk today is going to be by Dr. Nithya Prasannan. I'll let her introduce herself formally, but she's going to talk today about VTE prevention in pregnancy and postpartum, focusing on risk assessments. So this is something which is very much ingrained within our national guidance within the UK, risk assessing women when they book in pregnancy and really identifying those women who are higher risk of thrombosis in order to intervene. So she's going to talk to you today about what we do. So welcome, Nithya. Thank you very much for coming to present today.
Thanks very much, Jill. Hello, everyone. My name is Nithya. I'm one of the haematologists based in London. And I'm just going to quickly try and share my slides. Can you see that all right?
Can't see it yet.
Not come through yet, no.
Oh, okay. Okay, how about
Yeah.
now? You can see that?
Perfect.
Perfect. Yeah. Okay, great. So it's really nice to be able to talk to you all today. And as Jill said, I'm going to talk about VTE in pregnancy and in the postpartum period, but focusing mainly on VTE prevention and the importance of VTE risk assessment and thromboprophylaxis. So this slide gives an overview of VTE during this period, and this data is from the UK and shows that 1 to 2 per 1,000 pregnancies are affected by VTE. So this consists of PEs and DVTs, they're the common forms that we come across. And there is a risk of developing post-thrombotic syndrome following a DVT. There is actually an old systematic review which looked at the prevalence of VTE in Africa during high-risk periods, such as post-op and also during pregnancy and postpartum. And that showed that the prevalence of DVT specifically was around 400 per 100,000 births per year. And then a more recent paper, so towards the end of 2025, looked at the VTE rates in Uganda and found this to be approximately 0.5%. So that's just to give you an idea of the numbers that we're looking at. For any woman who has a VTE, so venous thromboembolism in pregnancy, they should be treated with low molecular weight heparin at a therapeutic dose, which is guided by weight. For pregnancy-provoked VTE, we should always ensure that they are anticoagulated out to 6 weeks postpartum with a minimum duration of 3 months. In the postpartum period, they can either choose to continue low molecular weight heparin, or if they're struggling with injections or are dependent on anyone to do this for them, then warfarin is certainly an alternative. Both of these agents are safe in breastfeeding, so that's important that these women are aware of that as well. In terms of warfarin, it sounds like an attractive agent because it's a tablet. However, they must be warned about the requirement for INR testing, particularly initially when they're being loaded and they're started on warfarin. They also need to be made aware of the possibility of requiring low molecular weight heparin cover if their INRs are subtherapeutic as well. DOACs are not currently recommended during breastfeeding, and that's mainly due to a lack of data. If the woman is not breastfeeding, then by all means, a DOAC can be considered. We would generally advise sticking with low molecular weight heparin in the first sort of week or 10 days postpartum to ensure that the PV bleeding, the lochia is all settling and there's no other bleeding concerns. But after that, a DOAC can be considered if they are confirmed not to be breastfeeding. Interesting, there's actually some early data that's emerging from the King's College Hospital group who have been looking at assessing the amounts of apixaban or rivaroxaban that's excreted in breast milk with modeling studies. And as I said, it's all early data, but it seems to be favoring rivaroxaban. In terms of delivery planning, this requires a multidisciplinary team approach. So with yourselves, the obstetricians, us haematologists, and of course our anaesthetic colleagues who will be able to advise these women on the different modes of analgesia and also the use of neuraxial as well. All these women should have an individualized delivery plan documented, ideally by 32 weeks, to ensure that there is a plan in place by that time. All women with a history of VTE require thromboprophylaxis in subsequent pregnancies, and this should be part of the counselling that the woman receives. It also specifically highlights the need for specific counselling for women who have a VTE outside of pregnancy, such as following a long-haul flight or following surgery. They need to be counselled and made aware about the need for thromboprophylaxis with low molecular weight heparin as soon as they obtain a positive pregnancy test. We may also have women who are already anticoagulated, so on long-term anticoagulation such as DOACs, and these women should be switched to an equivalent dose of low molecular weight heparin as soon as they become pregnant. So this next slide is a really informative one, which I've taken from a paper back in 2013, actually, and it shows the incidence of VT from the non-pregnant state throughout the different stages of pregnancy and in the postpartum period. The three lines generally follow the same trend, but just so that you know, it just shows where the data has come from. So it's either data collected from primary care, secondary care, or a combination of both. And what it shows is that the rate of VT increases slowly as you enter the first trimester, with a further increase in the second trimester and a more obvious increase in the third trimester. This is then followed by a significant peak around the time of delivery and within a week postpartum as well. That rate starts to drop over the next 5 weeks postpartum, but is still significantly raised until about 6 weeks postpartum, at which point they come down to the sort of the baseline population risk or thereabouts. And this explains why we advise anticoagulating out to 6 weeks postpartum. So the key takeaway message from this slide would be that the highest risk of VT is in around the time of delivery and a week postpartum, but also that the VT risk starts to increase as early on as the first trimester. And that really suggests that women who are at high risk, so for example, those who have had a blood clot before, should ideally start thromboprophylaxis as soon as possible after obtaining a positive pregnancy test. This takes us on to VTE risk assessment, and this is from the RCOG, so Royal College of Obs and Gynae guidelines, which is largely what we follow in the UK. This provides a way to risk stratify women for VTE. And I appreciate you're likely to have your own risk assessment tools and strategies, but I thought it was still good to just talk through this, as I'm sure there's lots of similarities and it's a way of sharing ideas as well. So we mentioned before, any woman with a previous VTE is usually considered for thromboprophylaxis from the positive pregnancy test. In the next box, we've got intermediate risk factors, which includes medical comorbidities, and this may not be as straightforward. So, for example, if a pregnant woman has also got cancer, which is very, very rare, but we do see very occasionally, we know that cancer is associated with a higher thrombotic risk, as is pregnancy. So this almost always calls for thromboprophylaxis in pregnancy and in the postpartum period. There are also other conditions. So for example, inflammatory conditions such as inflammatory bowel disease, where disease may be quiescent, but there is a risk of flare at any point during that pregnancy or afterwards. So it's really important to bear in mind that these women require more of a dynamic VTE risk assessment, and the importance of counselling so that they are aware that they should seek help if they develop an inflammatory flare during pregnancy or postpartum. Particularly with inflammatory bowel disease, there is a risk that this can flare up in the postpartum period, having been completely fine during pregnancy itself. And in the postpartum period, this may be at a time when these women are no longer under regular follow-up. So again, it's really important that they know to seek help and who to contact if they develop a flare, at which point their VTE risk assessment should be reassessed. The third box looks at the more sort of common risk factors that we come across, such as age over 35 and a BMI greater than 30. These are usually picked up at the booking visit by the midwife. As you can see, so the other risk factors there are parity more than 3, being a smoker, having gross varicose veins, a diagnosis of preeclampsia, immobility. Family history is also there, and this is of first-degree relatives with a blood clot. So these are either parents or siblings who have had an unprovoked blood clot. So where a PE or a DVT, for example, has occurred, but an obvious provoking factor has not been identified. That will enable these women to score 1. Likewise, if mum or sisters have had a blood clot during pregnancy or the postpartum period or associated with a combined contraceptive pill use, this would also score the 1 point as well. Underneath that, we've got low risk thrombophilia. So as you will know, so a thrombophilia is when there is an inherited tendency to form blood clots. And a low risk thrombophilia includes things like heterozygous factor V Leiden and prothrombin gene mutation. Multiple pregnancies, so twin pregnancies and so on, are associated with a higher risk, as is IVF. Anyone who scores 4 or more are at high risk and should start thromboprophylaxis promptly. If they score 3, then our usual practice is to give thromboprophylaxis with low molecular weight heparin from 28 weeks. Anyone who scores less than 3, so 1 or 2, a score of 1 or 2, they don't usually qualify for antepartum thromboprophylaxis with low molecular weight heparin. However, there is definitely advice we can give about conservative measures. So this is ensuring that they continue to mobilize even during the sort of the later stages of pregnancy, and also keeping well hydrated to reduce the risk of dehydration. Transient risk factors are also important to consider. And again, this is when counseling is really important and the women know when to seek help. So this includes things like hyperemesis, where there's a risk of dehydration, but also infection as well. And I will touch upon hyperemesis a little bit more in the next few slides. On the right side, on the other side, we've got postnatal VTE risk assessment, and this works through very similarly, actually, but also has other risk factors included, which are more relevant postpartum. So the type of delivery you had, whether there was any preeclampsia, whether the pregnancy ended with a stillbirth, which comes with a higher risk. The duration of labor, particularly prolonged labor, more than 24 hours, infection during this period, and also PPH as well. So the next slide summarizes the key points from the last 2 Embrace UK reports. So Embrace stands for Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries Across the UK. And what they do is try to look into causes and contributing factors for deaths that occurred during pregnancy and in the postpartum period. And the 2024 report shows that of the 275 women that died, 16% were due to thrombosis and thromboembolism. And again, in the 2025 report, which is our latest report, blood clots were again the leading cause of mortality during pregnancy or up to 6 weeks postpartum. So risk happens early. So we saw in the graph that I showed earlier that the risk starts to increase as soon as you go into the first trimester. So it's really important to start thinking about VTE risk very early on, i.e. as soon as a woman becomes pregnant. We also discussed earlier the importance of considering transient risk factors such as hyperemesis, and these are the women that need more of a dynamic risk assessment because this risk is not static. So some women may get hyperemesis fairly early on during the pregnancy, whereas others may get it sort of later on in the first trimester and so on. So again, it comes down to highlighting the importance of counseling these women that hyperemesis does come with the risk of blood clots and that they must seek help if they develop such symptoms. Of course, as I mentioned before, infection is also another transient risk as well. So the next couple of slides, I'd just like to go through a couple of case studies that I've taken from the Embrace UK report, just to try and highlight some of the risk factors that have been identified. So in the first case, we've got an older multiparous woman. So greater than 35 years old and para greater than 3, who's presented with vomiting late on in the first trimester. She actually did have a history of hyperemesis in her previous pregnancy and was prescribed an antiemetic by her GP, but without any further assessment. 2 weeks later, she attends for her first booking visit with her midwife, who realizes she's still vomiting and is clearly concerned and refers her to the emergency department for review. Whilst in the emergency department, she has a VTE risk assessment done, but this was not done using a pregnancy-specific risk assessment. This was done using the hospital's local risk assessment tool, which is geared towards non-pregnant women. She was classed as low risk and therefore discharged with the advice to continue cyclizine at home. A few days later, her vomiting settles, but she develops pain in her leg, which has been persisting for 2 days. She did try to arrange an appointment with her GP, but unfortunately collapsed and died at home before this was possible. And a post-mortem confirmed the cause of death as a DVT and bilateral PEs. So the key message here is about VTE risk associated with hyperemesis and how these women are at risk. It highlights that women require different VTE risk assessment that is specific to pregnancy rather than a non-pregnant assessment tool. Now, we would generally regard any woman in pregnancy who attends with hyperemesis, so certainly if they come to the emergency department requiring IV fluids or antiemetics, to be at higher risk. And these are the women that we are considering for thromboprophylaxis. In the last year or so, we have locally set up a hyperemesis pathway to try and raise awareness, but also to highlight that this is a high risk group of women. So these women get risk assessed, often with maternal medicine input, which is very valuable, and they go into the hyperemesis clinic where that will be dealt with, but also their VTE risk is continually reassessed as well. So the next case is of a morbidly obese woman. So in the RCOG guidelines, we mentioned that a BMI greater than 30 gives you a score of 1. A BMI greater than 40 will give you a score of 2. At booking, this lady was classed as low risk for VTE. She goes on to have a spontaneous vaginal delivery at term, did have some issues with blood pressure, which subsequently settled, and she was discharged with 10 days of low molecular weight heparin. Her VTE risk assessment was not repeated prior to discharge, and 2 weeks after giving birth and going home, she becomes confused. She reattended and had a CT of her head, which showed extensive bilateral venous sinus thrombosis, and she sadly died 4 days later. So the main risk factor that's being highlighted here is a BMI greater than 40, so morbidly obese, and the fact that this risk factor is persistent, so it's unlikely to resolve in the next 6 weeks, so 6 weeks postpartum. Again, it's just to bear in mind that when we spoke about sort of antenatal and postnatal risk factors and VTE risk assessments, BMI is in there, and there's specifically a box that says if risk factors are persistent, then we may consider increase in duration. In reality, I don't think that's always done, but this case highlights, the need to look more into high BMI. And in one of my later slides, we will talk about what the actual risk of VT associated with a high BMI is. There's also a mention here of a high blood pressure. There's not much more detail, but I guess we don't know when that started and if preeclampsia was implicated in this case or not. So they then went on to see of the women who died because of blood clots, did they have risk factors for VTE? And yes, majority did. So BMI, 40% had a BMI of 30 or more, yet the equal amounts of 42% had a BMI between 25 and 30. And this is interesting to see because according to our current RCOG guidelines, anyone who has a BMI less than 30 does not score a point. Age, so approximately a third were aged between 25 and 39 years old, and 6% were over 40 years old. And we're definitely seeing an increasing age in pregnancy now. 22% were smokers, and 21% had a history of previous VTE. 44% had an operative delivery and had postpartum VTE. So in terms of takeaway lessons, we have already discussed the importance of pre-pregnancy counselling. So this is down to whenever the first clot happens. So this would usually be in the hands of the haematologist or anticoagulation team. So to counsel women of childbearing age on the risk of VTE and the need for thromboprophylaxis in pregnancy, but also to ensure that the women remember this, there's something documented, and that they start thromboprophylaxis with low molecular weight heparin promptly when they obtain a positive pregnancy test. It's also important that these women are counseled of the signs and symptoms of VTE and when to seek help if they develop any concerns. So VTE risk assessments should be repeated, particularly intrapartum and postpartum are periods when we have found that it's not always done so well. So according to the RCOG guidelines, the VTE risk assessment is usually first performed at booking, and then it should be repeated at certain intervals. So at 28 weeks, when a woman presents for delivery, in the immediately postpartum period, which is generally within 6 hours, and for any additional admissions that they may have. That includes other bleeding concerns or other concerns to do with pregnancy itself, but also for miscarriages and terminations within the last 6 weeks as well. Again, transient risk factors such as COVID-19 or any other infection, high premises. If women present with these, they should have their risk assessment repeated. We did have an audit that was done locally by the obstetric team here at UCLH, which identified that this is not very well done when they present for delivery and in the immediately postpartum period as well. So particularly for women who require 6 weeks of thromboprophylaxis, our job doesn't just end with prescribing the 6 weeks course. We need to ensure that these women understand the importance of compliance with low molecular weight heparin thromboprophylaxis, and we need to find ways to try and keep them engaged and improve compliance rates. Again, the audit that was done locally here actually found that particularly in the postpartum period, this audit analyzed women who were discharged with 6 weeks of thromboprophylaxis. And what they found, which was done through telephone calls to these women later, was that majority of patients did not complete the 6 weeks course. So the compliance rate was actually less than 50%. On further questioning, it was quite apparent that they'd been appropriately counseled. They knew that they had risk factors for VTE. They knew that low molecular weight heparin is what the recommendation is, would hopefully help to reduce this risk. And they also understood that there is a risk of life-threatening blood clots. But I think the postpartum period is such a challenging period for these women with a new baby and lots of other things going on. So they tend to compliance tends to reduce after a couple of weeks. And particularly after 4 weeks, it goes right down. Thrombolysis. So if someone presents with a life-threatening PE, then thrombolysis can certainly be considered. And this requires a multidisciplinary team approach. So hematologists, maternal medicine team, ITU or anaesthetist, acute medicine, and of course radiology or interventional radiology. Maternal medicine team. So obviously different hospitals have different networks and so on. But involving the maternal medicine teams, when a pregnant woman presents to hospital with medical issues is crucial, because they are much better at, firstly, risk stratifying for VTE, but also advising management of these medical issues during pregnancy as well. What I'd like to do for the second half of the talk is change gears and steer completely away from low molecular weight heparin and look specifically at postpartum thromboprophylaxis and just try and highlight the what evidence we actually have for all these guidelines recommending low molecular weight heparin as thromboprophylaxis. And the question really is low molecular weight heparin best in this period? So most guidelines that recommend postpartum thromboprophylaxis are not actually based on data that has come from large efficacy randomized controlled trials. They're also based on observational data, risk modeling, and expert consensus. So this slide shows just an overview of some of the studies that have been done in the postpartum period, and I'll just quickly run through them. So we've got the PROSPER trial, which was done in 2015. So this was postpartum thromboprophylaxis for PEs. This was a feasibility study, so which looked at low molecular weight heparin versus placebo for 21 days postpartum. The group of women that they were recruiting were high-risk postpartum women. And this is very similar to the inclusion criteria of the partum trial, which I'll go into in more detail shortly. So we'll come back to what these high-risk inclusion criteria include. In terms of findings, so out of the 378 women that were screened and found to be eligible, only 25 were recruited and randomized. So it's a really, really small number. So very poor recruitment rate, and therefore efficacy could not be assessed. There was no safety signals, but we're talking about 25 women. So this is by no means, large enough to draw any strong conclusions from this. The PP postpartum HEP trial, so this is postpartum heparin against VTE, was done in 2024 and looked at enoxaparin for 10 days versus no treatment. And the enoxaparin dosing was based on the weight. So generally, if the weight is less than 50 kilos, we'd go for 20 milligrams, a weight between 50 and 100 kilos, 40 milligrams for enoxaparin, and above 100 would be 60 milligrams. This was the intermediate risk postpartum women. So this was the intermediate risk box risk factors that we saw in the RCOG guidelines. And again, out of the 480 women that were screened and found to be eligible, only 77 were recruited. So better than the PROSPER trial, but still a very low number. So even though the feasibility was a bit better, they were still underpowered for efficacy. Again, there was no safety concerns here, so no VTE. And then at the bottom, we've got the LEAP trial, which is low molecular weight heparin versus aspirin from 2024 as well. And this in this trial, they used 6 weeks of low molecular weight heparin versus 3 weeks of low molecular weight heparin, plus an additional 3 weeks of aspirin. So this is probably one of the first trials that's starting to look at a change from what we are used to in terms of low molecular weight heparin. In terms of the women that they were recruiting, so these were women who would usually receive thromboprophylaxis for 6 weeks, such as those with a previous VTE, or for example, if they're homozygous for factor V Leiden with a family history of VTE. So fairly high-risk women. Again, the same problem. So of the 67 women that were screened, only 30 were recruited. So what this is showing us is that there has been lots of efforts to try and perform feasibility studies in the postpartum population, but the message from all 3 trials is the same, that this is a group of women that are very difficult to recruit into clinical trials. And this is really important because without a large randomized clinical trials, we don't have any strong evidence for what we are doing. So moving on to the partum trial. So I'll just quickly talk through the trial itself, how it was conducted, and then we'll move on to the results. So as I said, this was a feasibility study. So the main aim was to see, is a large randomized control trial that compares aspirin with placebo feasible in the postpartum period. Of course, they did also evaluate safety and efficacy, so to see if any of these women had any symptomatic blood clots, whether there was any bleeding concerns, acceptability. So driving change in medicine is very difficult. So for a population in whom we are very used to giving low molecular weight heparin thromboprophylaxis, it was important to see whether the idea of aspirin would be accepted. And of course, adherence to the tablets as well. In terms of study design, this was a randomized, double-blind, placebo-controlled trial, multinational recruitment across 7 centers, 4 of which were from Canada, and then 1 each from France, Ireland, and the Netherlands. They were open for recruitment for 6 months, followed by a 3-month follow-up. And the recruitment period is small just because this was a feasibility trial only. And the women who were recruited underwent block randomization. That's just to try and ensure that we have an equal number of women in the different arms, so placebo arm and the aspirin arm. So inclusion criteria. So this is very similar to the Prosper trial. So any postpartum woman who is 18 years of age or older who have got identifiable VTE risk factors. So needed 1 or more first order or major criteria. So this includes mild to moderate inherited thrombophilia. And these would include things like heterozygous factor V Leiden or prothrombin gene mutation, protein S and protein C deficiency. They also use antenatal immobilization as a major criteria. So this is when a woman is in bed for more than 90% of the time that they're awake for a week or more. In the next slide, I will go through a little bit more about why they looked or chose this particular risk factor. But before moving on, so they could also have 2 or more second order criteria. So this is a pre-pregnancy BMI of 30 or more. According to our RSCOG guidelines, it actually recommends using the booking BMI, whereas in practice, in reality, majority of us would go by a current BMI. The rest of the second order criteria included a positive smoking history in the pre-pregnant state, a history of superficial vein thrombosis, so whether that's in the current pregnancy, previous pregnancy, or completely unrelated to pregnancy, preeclampsia, whether a pregnancy ended in a stillbirth, whether they required an emergency C-section, whether the infant was small for gestational age at the time of delivery, if they had a postpartum infection, or a PPH, which was more than 1 liter. So this slide is taken from another paper, which looks at the different VTE risk factors and what the risk of actually developing a VTE is. So you can see that with a parity greater than 3, the odds ratio was 2.4. We spoke about BMIs earlier. So in this study, they've shown that a BMI of 25 or more was associated with an odds ratio of 1.8. However, when you've got a BMI greater than 25 plus antepartum immobilization, so this is when they're mainly bedbound for a week or more, the odds ratio shoots right up to the 60. So that's a really, really big risk. And that would explain why antepartum immobilization was one of the major criteria in the partum trial. We've also got other risk factors there. So a prior VTE was associated with an odds ratio just below 25. We've got sickle cell disease with an odds ratio of 6.7. On the other side, we've got pregnancy risk factors. Intrauterine growth restriction was associated with an odds ratio of 3.8, which was actually higher than preeclampsia with an odds ratio of 3.1, and again higher than having a twin pregnancy, which had an odds ratio of 2.6. At the bottom, we've got delivery characteristics. So looks at the different types of deliveries. An emergency C-section had an odds ratio of 2.7, but a stillbirth had an odds ratio of 4, so much higher risk there. Infection during delivery or around delivery was associated with a higher risk, particularly if it was a vaginal delivery where the odds ratio is over 20 compared to infection during or after C-section, which was associated with an odds ratio of 6.2. And we can also see that a PPH was associated with an odds ratio of 4. So that just helps to give us a clearer idea of what are the major risk factors in pregnancy or postpartum. So going back to the partum trial, this just sets out the exclusion criteria. So anyone who was under 18 years were excluded. If it was more than 48 hours since delivery, they were also excluded. If they'd had more than 2 doses of low molecular weight heparin since delivery was part of the exclusion criteria. So in this trial, they were allowed to receive either 0 doses of low molecular weight heparin 1 or 2 before they were recruited onto this trial. But anyone who had received more than 2 doses were excluded. Women who require anticoagulation for other reasons, such as previous VTE, mechanical heart valve, so much higher risk, or high-risk thrombophilias were recruited. And I think that's a very sensible approach in ensuring that we're not making a drastic change from what we are used to in the high-risk population. Likewise, anyone who required postpartum aspirin for other reasons, such as previous stroke or MI, were also excluded. If there are any contraindications to aspirin, such as allergic reaction or based on counts, severe hypertension, and active bleeding. So once eligibility was confirmed, they were randomized to aspirin 80 milligrams or placebo, and this would generally commence between 6 hours and 48 hours post-delivery and continued for 6 weeks, which was the total duration. So all these women had a baseline visit and then a follow-up at 6 weeks and again at 3 months. And that included a variety of consultation modes, so face-to-face, telephone, video calls were also possible as well. All these women who were recruited had to document whether they used non-steroidals or were breastfeeding, and they also recorded the compliance to the medication, whether it was placebo or aspirin. So this trial actually took place during the COVID-19, or there was some overlap with the COVID-19 pandemic. And what they did was at the end of the trial period, so at the end of the 6 weeks, these women would send back their bottles of aspirin or placebo, and then the trials team would count how many tablets were left to try and find out what the compliance rates were. This is a flowchart that shows sort of screening and eligibility. And this is also interesting to see because it just again highlights how difficult it is to recruit women into these trials. So over 10,000 women were screened for eligibility, of which only 1,179 met the inclusion criteria. Of these, a majority were excluded, so 922 women were excluded. Over 600 of these exclusions were because of non-consent or not wanting to participate in a clinical trial. And 286 were based on not meeting the eligibility criteria, of which almost 60% was because they had missed the boat. So they had been more than 48 hours since delivery. In this trial, majority of centres approached these women in the postpartum period, so after delivery, but 2 centres did approach them in the antenatal period, so usually in the 3rd trimester, to try and raise awareness so they're not hearing about this trial for the first time in the postpartum period. Following sort of exclusions because of either being lost to follow-up or withdrawal, there was 121 in the aspirin arm and 122 in the placebo arm. And then moving on to results. So this shows the demographics, and we can see that between the 2 groups, so the aspirin group and the placebo group, they were fairly well matched for age, race, pre-pregnancy BMI, and parity. But you can see that majority of cases, so over 80% of cases were recruited from Canada, with a much, much smaller percentage from the other recruiting centres. In terms of VTE risk factors, so approximately 2% had inherited thrombophilias. In terms of antepartum immobilization, 6% were immobile in the aspirin arm and 2% in the placebo arm. All the other risk factors were fairly well matched, except for postpartum infection, where you can see this was 6% in the aspirin arm and 12% in the placebo arm. At the bottom, it looks a bit more into sort of the types of delivery, so whether they had an induction, a C-section, which was either planned or an emergency, and if they required any assisted delivery for the normal deliveries. And then medical comorbidities, which we spoke about earlier and identified as, some of these can be risk factors for VTE. So again, fairly well matched. And the sort of common risk medical conditions that we would come across as well. So asthma, hypertension, diabetes, heart disease, renal disease, SLE, Sickle cell disease, they didn't have any women. We've certainly got a large sickle cell population here. And we know that these are women with a high risk of VTE. So that would be really important to see, if the outcomes when it's done in a larger trial would be applicable to women with sickle cell disease as well. And at the bottom, it's just a little bit about what I mentioned about the number of doses of low molecular weight heparin that they were allowed before being recruited onto this trial. And as you can see, so majority, so 55 to 60% did not receive any doses. And then here we've got a table of feasibility outcomes. So this is a feasibility trial, so we need to ensure that enough patients are recruited per site. And their feasibility target was 4 patients per site per month. And actually they recruited more, so they had 6.3 patients per site per month. So that target was met. And then at the bottom, you've got study medication adherence more than 80%. And the feasibility target was greater than 70%. So of the 69% of bottles that were returned, 74% had taken more than 80% of tablets, so they met that feasibility target as well. And then here's the main safety and efficacy outcomes. So luckily, no major VTE, so no major blood clots in either groups. In the placebo group, one lady did have a distal DVT, which was diagnosed about 5 days postpartum, and she did have identifiable VTE risk factors. So BMI greater than 40, preeclampsia, and also small for gestational age infant as well. No major bleeding concerns. In terms of clinically relevant non-major bleeding, so there was a few there, but these were all to do with sort of PV bleeding and within 6 weeks postpartum. Wound hematomas, so none of them experienced this in either of the arms, and well, certainly not requiring intervention or big enough to do so as well. So feasibility trial did manage to recruit more than the target number of patients per month. And that recruitment was definitely higher than the slide that I showed initially, sort of outlining the previous studies that have been done in postpartum women. But the sample size is still small. When we are talking about randomized controlled trials, we're talking about much larger numbers. So we're still not able to draw any strong conclusions. But reassuringly, there were no safety signals either with bleeding or with blood clots. This is actually the largest trial evaluating placebo controls from a prophylaxis intervention in the postpartum period. So we said that they did better than the previous trial. So they had an improved feasibility, and they looked into the reasons behind this. In the partum trial, they did not require any additional lab tests or imaging, which was really important and must have contributed towards the feasibility. So in the Prosper trial, women had to undergo bilateral Doppler ultrasounds and a blood test for a D-dimer at day 10. So it's quite early on in the postpartum period. So the fact that this trial didn't have any of those requirements would have helped improve the feasibility. The first follow-up in the partum trial was at 6 weeks, as I mentioned, and this is much later than the 10 days or 21 days in the Prosper trial. So it just means women have had a chance to settle into the postpartum period with a newborn at home. Again, we also mentioned the different types of consultation. So not having to necessarily come in person and being able to have those consultations, a telephone or video follow-up certainly helped with the feasibility as well. And then following on from this, the full partum trial is now underway. And this is more of a non-inferiority design. So it's comparing low-dose aspirin to low molecular weight heparin. And if non-inferiority is demonstrated, i.e. aspirin is as good as low molecular weight heparin at reducing or preventing blood clots, then this will have a massive impact globally. And there are several reasons for this. So low molecular weight heparin is an injection, which is always, well, not a very attractive option. These women are having to inject themselves daily throughout pregnancy and for 6 weeks postpartum usually. Women who struggle with sort of needle phobia or, are dependent on someone else to do these injections for them, that's a struggle, that's a challenge itself. But also cost implications. So certainly in countries where, the women are having to, buy these drugs themselves, low molecular weight heparin is expensive. On the other hand, if aspirin is found to be non-inferior, then it's a tablet, so much more attractive and easier to take, but it's also very cheap. It's also something that a lot of the population would be aware of, so they would have heard of aspirin use, for either secondary prevention, but also as painkillers, using it as analgesia for migraines. So it's something that these women have come across much more. So if following on from the full partum trial results, if non-inferiority is demonstrated, then that could lead to a practice change, essentially, which will benefit lots and lots of postpartum women. And thank you. Has anyone got any questions or anything?
Thanks, Nithya. Oh, can you hear me?
Thank you. Yes.
Hi. Actually, if you just close down your presentation, I should be able to see. There you go. I can see you better now. Thank you for that. No, that was really interesting. Thank you. One of the things I think I would ask a question, really, maybe of our colleagues in Lusaka is, I don't know if everyone's able to the technology will allow, but could you share what's your approach currently to thromboprophylaxis within the maternity units? How much is it used? How much is it widespread? I'm interested to learn about what you currently do. Alton, are you still there? Can you hear? There you go.
Yes, Dr. Swallow, I can get you. So for UTH, the women and newborn, we follow the same protocols that were set for the NICE guidelines for thromboprophylaxis, but we tend to give it more for patients that are like sickle cell disease. Then for postpartum, those who have had cesarean section, we give especially those that are obese with a history of thromboprophylaxis. We use it quite a lot, although the cost is it's expensive, and fortunately it was covered by the insurance scheme. But nowadays we see more where they give a shorter duration, so the patients have to keep on going back to get some more. So at some point we've had patients who, if they have like a deep vein thrombosis, then you put them on low molecular weight up to somewhere 13 weeks. Then you switch them to warfarin up to close to 36 weeks. Then you switch them back to the low molecular weight heparin.
Okay, and is that a cost issue? Is that because warfarin is so much cheaper than low molecular weight heparin?
Yes, although it needs that constant monitoring with INR, but it tends to be cheaper in terms of buying as compared to the low molecular weight heparin.
Okay,
although the advantage for the heparin is the lack of there's no that frequent monitoring in terms of the factor 10 levels that.
Okay, and so we don't. Understand what you're saying about the anti-10A levels, and that wouldn't be something available. But actually, I think we do very little anti-10A monitoring of patients on therapeutic enoxaparin. We only tend to really do it if patients are known to have something that will cause heparin resistance, so for example, antithrombin deficiency, or I will occasionally check it in a patient who has clotted despite being on anticoagulation. But other than that, I don't know, Nithya, I can see you nodding. Would you say similar?
Yeah, no, absolutely right. So this would be for the women who are on therapeutic enoxaparin. So we generally don't either, unless of course there is clot progression or anything, which is very, very rare, to be honest. But otherwise not. Heart valves, we tend to do it more so the anti-10As with them, just to make sure that they are doing okay and staying within the target, but otherwise generally not.
Okay. Okay, so sorry, Oshnia, you were saying, so you're following a similar guideline to what we would use in the UK with the alcohol. My other question, Autumn, again, to you and your team, is that do you do you have a good idea of how much thrombosis you see in your pregnant population? Do you have any data, or do you collect audit data on patients to sort of getting a good idea of how many of your women actually present with thrombosis?
Unfortunately, that data is not systematically collected, but we've seen a number of cases where you do maybe a procedure, then 2-3 days later on, a patient comes back with difficulties in breathing or worsening respiratory symptoms. So nowadays we are a bit more cautious as opposed to before in terms of thromboprophylaxis, because we've seen a number of patients that come back with events that are suggestive of venous thromboembolism.
Yeah. Okay. And for your patients who are taking therapeutic doses who have clots, are you using a twice daily dose of enoxaparin, or do you use it or once daily? We use enoxaparin. Sorry, that's why I keep saying enoxaparin. Do you use a once or a twice daily dose of your anticoagulant, your luminocort heparin?
So for the therapeutic dose, we tend to use the twice daily. We also have enoxaparin, which is commonly available. So it's the one that we tend to use more, the Clexane brand. Yes. So we use twice daily for those that we feel that they need treatment dose. But for those where we are just suspecting the diagnosis, or the ones that we are just giving thromboprophylaxis, we tend to give the once daily.
Once daily dose. Yeah. Okay. So I'll open it up. Are there any other questions? Anyone else wanted to ask any other questions of Nithya or myself while they're on the call? Okay, so I can't hear anybody at the moment. So that's fine. And as ever, we're always happy to be emailed with queries after the event. In that case, then I think what I'll do, I'll bring the session to a close. We're not going to have a session next month in August. It falls over our holiday period here, so it'll be very difficult to organise speakers, and I'm actually away. So our next session will be the first week of September, and I will, Autumn, I will email your team the titles of the topics that were upcoming. As ever, we're really keen that which we present is useful, helpful, relevant to your practice. So anybody on the call, if you've got ideas for topics, if you've got things specifically you would like us to present, if you've got interesting cases, you think that would make a good basis for a discussion around about a case, we're really keen that you send us those by email so that we can focus it on what's going to be the most interesting for you. And also, we're really interested at our end to learn how things are done differently elsewhere and to learn from practices that are different from our own. So I think it's it would be nice to talk about some cases. Okay, well, thank you everybody for attending. Nithya, thank you so much for presenting today. We appreciate it.
Thank you so much for having me.
And we'll see you all next month. Have a good rest of your day.
Take
care. Bye.
Thank you so much.
Take care. Bye.